be of interest. And at the same time, allow you guys to ask questions. So, um, one interesting case that showed up today, it's a 50-year-old. She is doing donor eggs, and she has not had a period for the last 2 years. And a few months ago, she was trying to do a transfer for from her embryos, and we could not get her lining to get thick enough. Okay, so she was having lining issues, most likely due to being postmenopausal for over 2 years. So, what did we do with her? She is getting ready. We have done a lot of progress in the last 3, 4 months, and she's actually getting ready. So one thing that we did is we put her on birth control pills, so she can start cycling, kind of stimulating the uterus and that lining to start cycling. So we did that for the last about 6 months or so. She was also doing acupuncture, and we did PRP. We did serial PRP, and supplements. And during the last time that we tried to transfer, we were adding the Viagra. That seemed to help a little. So I am very optimistic. Today we did a baseline for her, and her uterus is looking a lot better. So she is getting ready for an attempted transfer next week. We did a PRP on her today, so that was fantastic. Even doing an endoscratch PRP on people with lining issues can stimulate that lining. So imagine that the endometrium is the soil, and you're tilling the soil and putting some fertilizer, so stimulate that lining to grow. So I see that I have some questions already. If you have any lining questions, go ahead and add them too. What should your number for progesterone and estrogen for a fresh transfer? I see a lot of girls go for a fresh, then get canceled. Okay, so what determines that a fresh transfer it's a go is one, the lining at the time of retrieval is trilaminar. What does that mean? That the exposure to progesterone is minimal. Two, the progesterone level needs to be less than 1.5. Honestly, less than 1 is ideal. Estrogen is not that big of a deal, and it can vary quite a bit, because then remember, the estrogen is going to be high depending on the amount of follicles that you have. So usually will be in the thousands, 1,000, 2,000, 3,000. It will drop after the retrieval is done, and that's why some of you will need estradiol if you're going to do a fresh transfer. Um, the other thing that we need to take into consideration, and it goes in correlation with those numbers, is the amount of eggs that are removed. So eggs will make estrogen, but they will also make small amounts of progesterone. That's why in certain occasions, if you had 20 eggs, your progesterone might be a little elevated, and that does not mean you ovulated. That means that between all of those good eggs, they were producing enough progesterone to get to that number, and then that will affect the quality of your lining. At the same time, if you have a lot of eggs, you're also going to have a lot more inflammation in your pelvis, and you're at higher risk for ovarian hyperstimulation syndrome. So then doing a fresh is not really a good alternative. But if you do not, if you have a low ovarian reserve, for example, and you did not get as many eggs, or your estrogen levels were not that high, then a fresh transfer is a good alternative. I see that with older ladies, and this is actually documented. With older ladies, it seems that fresh transfers are better. In the general IVF population, fresh transfers are about a 30% chance of success versus 50% chance of success with a frozen. And that 20% difference is kind of related to what happened at retrieval or whatever inflammation is there for the retrieval. I have a consult in December. I have 4 children naturally, got my tubes tied. Would natural IVF be my best answer? I don't really like promoting natural IVF. Natural IVF would be that you do not have any medication. We monitor you and you go for retrieval for 1 egg. Now, when you start taking eggs out of the body, no matter how good the quality is, you're going to lose some of them. So when you're going after 1 egg, you could end up with nothing. So me as a woman, if I'm going to go through IVF, I want you to take as many eggs out of me as possible. Because let's say I got 10 eggs. Out of those 10 eggs, maybe 1 or 2 are immature and they'll just die off. And then maybe some will fertilize, maybe some will not. And then out of 10 eggs, I'm going to end up with 4, maybe 5 embryos if I'm lucky. So even though it's doable, I just I don't think it's cost effective to do natural IVF. 4 PGT tested embryos transfer, 1 PGT tested embryo successful to 6 weeks, and 1 IUI. So Missy points out something very important. Having a normal PGT tested embryo does not guarantee a pregnancy. That is very, very important. That's why genetic testing on the embryos is so controversial. There's many factors involved. There's even controversy around if the actual biopsy might affect the way the embryo implants. So there's a lot of questions about that. For good and for bad, it is the best technology we have. So if it's important to you to either know the sex of the baby, to get the embryos tested, it is the best technology we have, but it will not guarantee a pregnancy. If I start my stims today but don't have my low dose ACG until tomorrow, can I take Menopur today instead, or will start? I don't like when people use both because it's not a 1-to-1 ratio. Menopur has FSH and LH in it on a half-to-half. So 75 units of Menopur is 35 and a half of LH. And 37 and a half of FSH. So usually we go with like 10, 20, or 30 of those SCG. So the dose won't be perfect. What I would recommend is just go ahead and start with your Follistim or your Gonal-F, and you can add the LH tomorrow. Okay. So Giselle is asking, she did a transfer. Her estradiol is 69. Should she take estradiol? I would. I'd like to see the estradiol above 100. How bad is endo for implantation? It is bad. I've seen a lot of women that will have documented adenomyosis or endometriosis, and they might end up having recurrent miscarriages or failed implantations. And then I see that if they take a break and do Lupron or Lisa, or laparoscopy and Lupron, or laparoscopy and or Lisa, it really brings out that inflammation, and then they end up having successful transfers. Do you recommend birth control to regulate periods if they're very irregular? I do. I've seen that with PCOS patients. They tend to do better when they have been on birth control pills, because then you have a better starting point, and the baseline in terms of labs, it's a lot better. PCOS patients tend to have more estrogen at baseline and a higher LH. So I see that their baseline is better if they have done birth control pills before their start date. I've had an endometrial ablation and a tubal ligation. Could I get an IVF? The tubal ligation, no problem. The endometrial ablation is going to depend if you're having periods, if there's any functional endometrium in that uterus. If you are having any form of period, then the answer is yes. If you have absolutely no periods and there's no functional lining in there, then you will need a surrogate. There are things that we can do, like I was describing at the beginning with the postmenopausal women, to try to improve that, but you have to have some lining left in there. I have worked with several women with scarring in their uterus and including endometrial ablation, and we have successfully healed the uterus, but they had some left in there. Having progesterone at 270, is it bad for midway lapse? That's pretty high. We like to see it about 30 to 70 is super high. I don't think it's bad, but it's definitely higher than what I normally see. CNY requirements for A1C for patients with type 2 diabetes. We like to see it less than 7. Honestly, I like to see it closer to 6. The closer to normal, the better. Elevated A1Cs not only will interfere with healing, not only will interfere with the actual process and how you respond to the medication, it is associated with birth defects. I had a miscarriage with a normal embryo. After we already saw a heartbeat, but baby stopped growing at 7 weeks. Next transfer, we're doing a modified natural cycle. I like modified natural cycles very much because it mimics what really happens in your body. Will it lower chance of miscarriage? I don't think so. Unfortunately, 10% of all pregnancies are lost for multiple reasons. Now, the good thing is that just because you had a miscarriage does not mean that the second time around is going to happen to you. Most of the times, it doesn't. Okay, I had my 5 weeks ultrasound today, and the OBGYN said my ovaries were enlarged. I have fluid and a large cyst. I did a fresh transfer. Can that cause miscarriage? Probably not. What's going to happen is if everything keeps going well, the ovaries during pregnancy, after 12 weeks, they tend to kind of quiet off. So the cyst is going to probably just go away. You do have something called a corpus luteum, and especially because you had a fresh transfer, some of your follicles will create a 1 or 2 corpus luteum that will help support that pregnancy. Okay. I just did 150 of Clomid and 7.5 of letrozole this past month. All right, Nicole. That's a lot of oral medication. I usually use either Clomid or letrozole. I don't really combine them that way. However, if you did not ovulate, then we need to see why. So in terms of, are we dealing with PCOS, insulin resistant? Should we do a keto? I mean, everybody should be on a keto or low carb diet. And then we could definitely do injectables. We can add metformin. There's a bunch of stuff that can be done to make sure you do ovulate. So if you want, we can discuss that, your particular case, in more detail. Just text me through Messenger. Okay, today's cycle day 1 for me, and I'm wanting to do a transfer this month, but I can't get in for my basal until Monday. Yes, April, that should be perfect. No problem. What would cause progesterone not to stay high? Some women, especially on medicated FETs, for whatever reason, can't keep up their progesterones. And I attribute it to the fact that they're not making it themselves. And somehow Our liver it's the one responsible for clearing our hormones out. So some livers are just more efficient than others. So what I would suggest is to do a modified natural cycle. So not only you get supplemental progesterone, but your ovaries are making progesterone as well. What is small fluid in the cul-de-sac? Is that an issue? Small fluid in the cul-de-sac, a lot of times it's a normal finding. It could be findings in relation of endometriosis or inflammation, infection. It could be a rupture cyst. So I wouldn't be too crazy. And a 4 centimeter cyst in the ovary is a little large. Because then what's going to happen to that ovary is that it won't respond as well to the medication. So what I would do is especially if you have PCOS, I would put you on birth control pills for a month. I would cover you if you have some free fluid in your pelvis with antibiotic, just to make sure we're not dealing with some chronic infection, and then program your IVF a month from now. Does it make sense to take birth control pills in a cycle if you don't have a period? Would you get a bleed when you stop? Most women will get a bleed, a withdrawal bleed, after taking birth control pills. There's a few exceptions. One, if we're dealing with lining issues. I have seen patients like our friend was talking, like endometrial ablation or scar in the uterus that will not bleed after birth control pills. I have seen people that were trying to get cycle, menopausal ladies that maybe have some spotting, especially at the beginning as we're getting that uterus to start kicking in. And I have seen PCOS patients. I had a patient a few years ago that for us to get her to bleed, she had to double up on the birth control pills. She was that resistant to medication. Okay. All right. I have 3 children conceived naturally. I've had 4 miscarriages, but all blood work and labs say I'm normal. Okay. So we would have to look at your case and see what else, I mean, do we need to check for endometritis? If you had 3 children, that is a lot of activity in your uterus. So I would encourage you to do an endometrial biopsy, potentially even empirically treat it. And then I would look at all of the, there's some specific blood work that we look for when people have multiple miscarriages. So I would look at that to see if that was done, and potentially treat you as a potential either immunological disorder or coagulation disorder, since the treatment it's really not that invasive. So I don't think IVF might need to be your next step, but a monitored time intercourse cycle with supportive therapy would be my thing for you. What's the cause of empty follicle syndrome and what's the treatment? So that's an interesting term. I wouldn't call it empty follicle syndrome. What happens is when we're younger, most of our follicles will have some eggs. As we mature, sometimes you're going to have, it's not that follicle did not start producing an egg. It might have died in the process, and then just, it's like kind of a egg miscarriage, if you want to call it that way. So the treatment, like I said, I see that more in the lower reserve patients, and you can do ovarian enhancement, supplements, BRP, human growth hormone, diet, to try to improve the outcome of the follicles, to try to improve the quality of the rescued eggs. So that's what I would do. Any suggestion on what to do after FET to make it successful? From the very basic would be, again, keeping the diet, supplements. And then looking at the adjunct therapies. If you had one failed FET or two, switching to a modified natural cycle, looking into the cavity again, endometritis, adenomyosis, any issues that could be interfering with successful transfers, and then ultimately doing an ERA. Is endo and low AMH related to high abnormals and poor response? Yes. Yes, it is. Endometriosis tends to affect ovarian reserve. So you will have, less amount of eggs and more frail or even abnormal eggs. And the meds, what does medication in general do? Okay. Medication, drugs are fantastic to provoke a biochemical reaction in the body. I had this discussion with another patient earlier today. But in order to create that biochemical reaction in the body, you have to have the biological reserve for that reaction to occur. And that's where the priming comes in. That's where trying to improve the quality of the eggs come in. So going higher on the meds, it's not going to improve your biological reserve. Improving the biological reserve to cause the reaction that you want with the medication, it's the homework. It's the diet, it's the supplements, it's the LDN, it's the human growth hormone, it's the priming. Okay. A couple of days ago, I've had a rash when I did my progesterone shot. That's very common. The progesterone shots come in different type of oils. By itself, even if you don't create an allergy to it, it is very irritating to the skin. There are different oils that we can switch it to. Some people become extremely sensitive and it's like they can't have it. Like they'll end up with like big red dots all over their bodies. And so we can try to combine other modes of progesterone, vaginal, oral, creams, when we cannot use the shots. And you can start by changing the oil that the progesterone's in. Would vaginal steaming before IVF be helpful? Absolutely. I like alternative modalities, vaginal steaming to do cleansings and stuff like that. Yeah. I would not do it through the process. I would do it in preparation of any type of fertility treatment. Okay. My estrogen today is 90, progesterone 5. My uterine lining is 11. No period yet. Do you advise starting stimulation or wait for my period? I would probably, if you haven't had a period and you have those values and you have stopped your medication, I would probably do some birth control pills. So, and then allow that bleeding to occur and allow those values to go down. Because I mean, progesterone, your values are too high to start. Do you think having unresolved cyst on ovaries from retrieval and swollen ovaries can cause FET to fail? Potentially, yes. And it has to do with inflammation in the pelvis. The uterus, the ovaries, they're all in the same place. So I would try to resolve that first. Is a drop in progesterone from 24 to 14 at midway indicative of failed natural transfer? No, there can be fluctuations. Actually, your hormones are fluctuating all day, all the time. You check in the morning and the evening, it's going to be different values. We do like to see a minimum, okay, and to protect the pregnancy, but that fluctuation is expected. Can a significant amount of uterine fibroids, tumors impact the ability of implantation? It can. Not only can it impact implantation, but it can increase chances of miscarriage. I have a patient and she ended up getting pregnant. She did not want to take out her fibroids. She ended up getting pregnant spontaneously on priming. And unfortunately, her fibroids were so big, she lost her baby at 20 weeks. I was wondering when Atlanta office will be able to do egg retrievals and transfers. That is a fantastic question. Um, it's been back and forth for a few years now. I know that you've heard this. Those of you that have been on this journey for a while, I don't know. I don't know when that's going to happen. I think that they're going to try to, they're going to try to get Sarasota up and running first. So I'm not completely sure as to what's next for us. Okay. Okay. I just had a day 3 fresh transfer fail. Have endo, did Lupron the cycle before, Neupogen on me, mini stim transfer to grade 4 and 3, did intralipids, urine PRP, ACG wash, acupuncture. So you did the works. You could have an immune issue, and you could have several things. You could have an immune issue. We could do an ERA just to make sure that you don't need more or less progesterone. Your age is not that big of a deal in terms of your uterus. If you're using your own eggs, we could be dealing with an egg quality issue. So we could look at, again, switching to a modified natural cycle. So just message me, because we would have to see, we would have to look at your particular case to say what can be added, what can be removed. Because sometimes too much of a good thing is a bad thing. If sometimes I see where people go crazy with all the medicine, then they go back off and they get pregnant. So okay. My progesterone came back to at 164. If it's too high, will affect. Nope, it's fine. I mean, we like to see the progesterone, special on IVFs, higher than 30. I've seen it, fluctuate from 20s to hundreds, and it's fine. I'm 18 weeks pregnant. I have a lot of headache. Even I take Tylenol, isn't working. Can you recommend something? So pregnancy is wonderful and horrible at the same time. So there's multiple things that you can do. You can do acupuncture for headache. You can do ice packs. You can do chiropractic care. You can see if there's anything in your diet that could be triggering some sort of allergy. Allergies don't only show up as rash or that's kind of what people expect. They can show up as headaches. So I would start looking at those things to see if any of that helps. A lot of times, milk will give you headaches. Gluten, wheat will give you headaches. And that will be maybe the only finding in terms of allergy. Will you get enough eggs if you do a back-to-back retrieval? Um, I know that some people do fine with that. The younger ladies tend to do better than the older ladies. I don't like doing back-to-back retrievals, especially on lower reserve patients, because it seems that if you do good on the first one, then the second one is not so great. What I do like to do is do retrieval, then take like a month break, retrieval. Okay. So not back to back where you do retrieval, come back and start the stim again. So imagine how the body works. The body works, go like a muscle. You go to the gym, right? You strain the muscle, but you have to let it rest. Same thing with the ovary. So you strain the ovary, you let it rest a little bit, and then you go strain it again. So then I see an improvement. Okay. So when I see retrieval, 1 month of retrieval, I see really good results that way. All right, so I'm gonna answer a few more. Time's up for tonight. You're always welcome to message me through Messenger. My name is Maribel Verdiales, and I will try to answer within 24 hours or get you on the schedule if you need to talk to me. ACG at 1588, 13 days after FET. How likely did embryo split, or is it common to have such a high beta? Yeah, it is common, okay? Betas are, how do I say this? We see with the beta, it's kind of a pattern. One, yes, it can split. You can have identical twins. Two, depending on how many embryos you transfer, if they both stick, then it's two pregnancies creating ACG. All right. Same thing as everybody freaks out about, it has to double every 48 hours. It doesn't really have to double every 48 hours. Rule of thumb is that it goes up about 60%. I personally like to follow the trend and correlate with the ultrasound, okay? Especially on IVF cycles, that so many things are a little different than spontaneous pregnancies. Okay. My AMH is 10. I'm 30 years old. They put me on ganoneric and low dose ACG and Lupron trigger. Does that sound appropriate? They didn't recommend birth control or antibiotics, which my prior ultrasound, blah, 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 blah. Again, April, you can reach me. Just write. I need your name, because some of you show up with like funky names. So I need your name, date of birth, and your phone number, and I will get somebody to put you on the schedule, and we can look at your case and see what else can be done to optimize your protocol. With your story, this is what I would do. Put you on 1 month of birth control with antibiotics to try to clear what's happening in your pelvis. And then if you have PCOS, then look at how much gonorelix or cetrotide is standard. That's kind of to avoid from you to ovulate prior to retrieval. We would have to see the amount of gonolef that was given. ACG at 20 is pretty standard. Depending on what your baseline LH is, we can drop it down to 10. Lupron trigger, that's okay. I prefer to do dual trigger, even if it's just a whiff of low dose ACG, like a 2.5, 2,500, because it tends to push the eggs a little bit to get them to be more mature. Sometimes what I see a lot with PCOS patients is they get like 30 eggs retrieved and then 20 of them are thrown out. So I like to go lower with the PCOS patients, maybe get less eggs, but then push a little harder such that we can get more mature eggs. All right, last question of the night. This is my how often does one take intralipids? You can do them weekly, no problem. You can do intralipids pretty much any time. During transfer. You can do them also during retrieval. To kind of help. What does the intralipids do? They can decrease inflammation, and they provide some of the raw material for you to make your own hormones. Okay. All right, everybody. It's been a pleasure talking to you tonight. I will be back in 2 weeks. If any of you wants to discuss your case individually with me, again, message me through Messenger, and I will get you on the books. The Atlanta office, the direct number is 770-266-3930. So feel free to call us. We're there to help. Have a blessed night, and God bless. Bye.